Hello, and welcome to today's webinar about Treat to Target and what that means to you as a patient with psoriasis. The National Psoriasis Foundation, also known as NPF, is a nonprofit organization dedicated to the mission of driving efforts to cure psoriatic disease and improving the lives of those affected. NPF is the world's leading patient advocacy group, representing more than 8 million Americans living with psoriasis and psoriatic arthritis. To accomplish the foundation's mission, the following goals drive everything we do as an organization: lead collaborative and transformational research in psoriatic disease, improve health outcomes by increasing the lifespan and health of individuals living with psoriatic disease, secure resources necessary to achieve our mission-related goals. By learning more about Treat to Target, you'll receive invaluable information that will help you gain a better understanding of how to manage your psoriasis and improve your health outcomes. Joining us today to provide information about Treat to Target is Dr. April Armstrong, who is the director of the psoriasis program at the Department of Dermatology at the Keck School of Medicine at the University of Southern California in Los Angeles, where she is also the vice chair and director of the Clinical Trials and Outcomes Research Program. Dr. Armstrong is particularly interested in the appropriate use of systemic agents, comparative effectiveness research, technology-enabled healthcare delivery, and comorbidities associated with inflammatory skin diseases such as psoriasis. Dr. Armstrong has conducted studies examining how new therapies impact patient disease states, quality of life, and their access to medical care. Dr. Armstrong serves as a member of the National Psoriasis Foundation's Medical Board and is a President's Council member, which represents an elite group of healthcare providers who are committed to the mission of the Foundation in finding a cure for psoriatic disease. As a member of the NPF Medical Board, she has been instrumental in the development of the Treat to Target initiative and is also active in the development of the American Academy of Dermatology NPF Guidelines of Care for the Management and Treatment of Psoriasis. Welcome, Dr. Armstrong.
Thank you very much, Bev. And I want to first of all thank everyone for your time today. So today we're going to learn a few different topics related to Treat to Target. First of all, what it is, and second, how to measure your body surface area, or BSA, and identify the level of psoriasis severity. Third, we're going to talk about how to prepare for visits with your healthcare provider. And then fourth, we're going to talk about how to track progress while you are on a treatment. So first of all, what is Treat to Target? Treat to Target, by definition, is treating a disease to a defined and measurable level of improvement within a certain time frame or time period. Now, this definition is very important, so I want to break it down a little bit more. So in our case, we are treating psoriasis to a defined and measurable level of improvement. That is, we want to treat psoriasis to a level which we understand to be clinically meaningful and important, and also within what particular time frame. So that's the target that we're going to talk about, and how we can really think about our treatment regimens with regards to their ability to help you achieve that particular target in a certain period of time. So why the treatment targets were created in the first place? Now, when we think about Treat to Target in psoriasis, it's actually one of the sort of later efforts that have been developed. In other areas of medicine, Treat to Target are well defined. For example, if someone has diabetes, we know that we want to look at their hemoglobin A1C level and to really treat to that level or maintain the patient's hemoglobin A1C level below a certain level. Second, I think something that's very familiar probably to most of us is blood pressure. So for example, the American Heart Association have defined goals or targets for blood pressure that we should maintain under. So these are examples in other areas of medicine in terms of Treat to Target and how we can really think about how to tweak our treatment regimen such that we are maintained at a target level that is optimal for our health. Now, defining treatment targets is important because if you don't know where you're going, how will you ever know how to get there? And it's important to help our patients and our healthcare providers to really make treatment decisions within a framework in which we have a specific goal in mind, as well as within a specific time period. And evidence have shown that when Treat to Target is implemented in other areas, typically people would experience reduced disease burden and have improved health outcomes. So I want to talk a little bit about how the treatment targets were created. The National Psoriasis Foundation Medical Board, as well as working in concert with patients and other leaders in the field of dermatology, came together to develop these treatment targets. There were 25 psoriasis experts involved, and these were essentially clinicians who treat psoriasis for the majority of their time. And through an effort, these treatment targets were developed, which I'll go over in greater detail about the process in later slides, and the results were published in the Journal of the American Academy of Dermatology. And these were really the first treatment targets in the US that had been developed. So this process in terms of developing treatment targets in psoriasis was a multi-stage process. So first of all, there was literature review, essentially involved looking at other countries, other continents with regards to what they did in terms of their treatment goals and treatment targets. Importantly, we also looked at different ways of measuring a particular endpoint to see what are the different ways in which we can come up with a definable end goal. We also had patients who participated in patient focus groups that gave us feedback with regards to what targets that they would like to see. And I really enjoyed working with our patients through that conversation. And one of the resounding messages that came from the patients were that the patients really wanted to be clear. And then we also surveyed the practicing dermatologists to see what would be an easy measure in which clinically that we can adopt to measure the disease severity and therefore measure a particular endpoint. And then number 4 is really the meat of the project, is where we had 4 rounds of the clinicians going through the expert Delphi process, in which people progressively come to a consensus with regards to what treatment targets should be. So what are the treatment targets? When we define the treatment targets, what we will see is that there are 2 important elements. Number 1, what is the measure that we're using to define a target? And number 2, what is the time frame? So what we see in this table here is that after initiation of a treatment, and it can be any types of treatment for your psoriasis, you want to have this ideally assessed at 3 months. Our aspirational target is body surface area of 1% or less. Now, what is considered an acceptable level is body surface area involvement of psoriasis of 3% or less, or 75% improvement from the baseline. And this is important because when we start a new treatment, sometimes 3 months after starting a new treatment, one may not have arrived at the ideal range for what that treatment can do. Therefore, we have this acceptable level of improvement that's listed here, being body surface area of 3% or less, or at least 75% improvement from baseline. So this is acceptable level of improvement. And then we have the target improvement, ideally where we try to get is BSA 1% or less. For patients with psoriasis, we want to ideally have an assessment of your psoriasis progress at least every 6 months. And if you are experiencing flares, you may need assessment schedules that's more frequent. So we had just talked about what to expect in terms of a target at 3 months. Now at 6 months and thereafter, every 6 months, the target should be 1% of body surface area involvement or less. So these are our aspirational targets, and it is something that's worth discussing with your healthcare provider in order to think about the regimen that you are currently on, and if you're not on target, how one can address that. So as you have seen, the measure that's used to really assess the target is what's called BSA, or body surface area involvement. So how do we measure the body surface area involvement? We look at our hands. So this is a hand print, and it has to be your handprint. So it can't be your husband's handprint or your child's handprint. It has to be your handprint if you're the patient with psoriasis. So one handprint of involvement is about 1% of your body surface area. So let's say you have psoriasis spots on your legs and they may be a little bit scattered. So you may want to imagine if they're all coalesced together, would that all come together into one handprint? And if so, Perhaps you would have multiple handprints. So if I put all the little pieces of psoriasis on one person's leg together, and if all that would occupy together is one handprint, then that person has a 1% body surface area involvement. So this is how we typically get a rough estimate of the percentage body surface area involvement of psoriasis lesions that one may have. What the targets are not meant to do. These targets are not meant to provide specific treatment recommendations. The target is 1% or less body surface area involvement of psoriasis, ideally at 3 months and at 6 months, and then be maintained thereafter. But as you can see, these treatment targets does not make any recommendations to say you should be on the biologic, you should be on the oral, and you should be on the topical, or a combination of those. And the reason is because each individual patients are different. And therefore, while targets are helpful to look at, how you get there needs to be an active conversation between you and the provider. Number 2 is that we explicitly stated that the treatment targets are not to be used by the insurers to deny any forms of treatment. And this is really important. In fact, I think our treatment targets have been used as a justification to expand the treatment options for our patients with psoriasis. So again, I want to emphasize that to achieve the treatment target, there are many different treatment options that may be available to meet these goals. And there's really no one-size-fits-all approach. So what the treatment targets are is that they can provide a basis for patient-provider discussion about the different treatment options. And it is important to know that there are a number of treatment options that can be discussed with your provider, and it really depends on whether you're achieving the goal or you're not achieving the treatment target. Few examples are you could either continue the current treatment plan and see if the psoriasis will continue to improve, whether you need to switch treatments, whether combining the current primary treatment for psoriasis with another treatment will be helpful, and possibly, while staying with the current treatment, perhaps increasing the treatment dose of a particular medication. And all that discussion should be framed with regards to one's level of disease severity, the type of psoriasis and the area affected, as well as, importantly, age considerations if a person is a pediatric patient and other medical conditions that may affect your treatment choice. So in whom that the treatment targets may not apply directly, this is something that I also wanted to bring up, because there may be extenuating circumstances where the risk of treating to target may outweigh the benefit of achieving that level of clearance for the psoriasis. For example, women planning for pregnancy may be under certain kind of constraints with regards to what they could do and what medications they can be on. And also nursing women, that's another area where the treatment targets may not apply precisely. For patients with psoriasis and psoriatic arthritis, in limited circumstances, the medication for psoriatic arthritis may be the best medication for the patient's psoriatic arthritis, but may not be the best medication for patient's psoriasis. In those cases, it's very important to ensure that a patient does not have progressive joint damage, and therefore, even if their psoriasis may not have achieved 1% or less body surface area involvement in terms of the treatment target, in order to make sure that their joints is well controlled, they may stay on the medication that's best for the joints, and that medication can cover both conditions, but we can sort of tolerate the psoriasis not getting quite to the treatment target level. Some of our patients may have other illnesses or health conditions that affect the psoriasis medications that they can take. So we want to really think about an individualized approach for those patients. And for pediatric patients, a lot of the discussion really centers around benefit risk assessment. So the benefit and the risks of having the patient achieve a 1% or less body surface area involvement need to be considered on a case-to-case basis. Despite of my talking about this, it's important to note the box down here, which says that it does not mean you cannot achieve these targets. It's just that in these specialized populations, it's important to discuss with a healthcare provider about the specific conditions. So let's talk a little bit about treatment options, probably one of my favorite topics in psoriasis. And we have a number of different treatment options depending on the level of severity. So I will actually start with the bottom of the slide, which you see are topical therapies. Topical therapies are most commonly used for patients with more limited involvement of psoriasis. And they are medications that are applied directly to the affected areas on the skin. And then phototherapy, there are a number of different types of phototherapies, but the two types that are typically talked about are either a booth type of phototherapy where you go into a booth, so the majority of your skin can be treated with ultraviolet light, or what's called targeted therapy, where it's a typically handheld device. Instead of a person going to a booth, they typically sit in a chair and the provider treats the spots with this targeted therapy. Now, booth type of phototherapy can also be delivered either in office or at home, and they can be effective in treating especially plaque psoriasis or another type called guttate type of psoriasis. Oral treatments and biologics are typically reserved for those with moderate to severe plaque psoriasis or other types of psoriasis. And oral medications, as the name suggests, are medicines that are taken by mouth. And biologics are really protein-based therapies that is typically given through a subcutaneous injection or shot or an IV infusion. Most of the cases these days, nearly all of our biologics that are approved for psoriasis and psoriatic arthritis can be given as a shot in the skin, and most of them can be given at home by the patients themselves. So when you're thinking about deciding these different treatment options, it's important to note that in this day and age, the main model that most physicians are leaning toward is what's called a shared decision-making model. That is the therapy that one will ultimately be chosen or choose for the patient is really through this shared decision model where you and your healthcare provider work together to make a treatment decision that's best for you. It's very important to note what is and what is not considered shared decision making because each of you play a different role here. It is still the responsibility of the provider to bring expert knowledge and to bring facts to the conversation. And it is still the role of the healthcare provider to make a recommendation because I don't think it's fair to any patient to say, well, here's treatment A, B, C, D, E, F, and G. Which one do you think is most appropriate for you? I think it's probably a much preferable situation where the physician or healthcare provider comes say, here is treatment A, B, C, D, E, and G. Here are their kind of benefits and side effects. I think in your particular case, given what you have in terms of other health problems and so forth, that this is the best treatment. Now tell me what you think about it. And then do you have any questions? And in this shared decision-making process, it is important that you as a patient understand the disease and the treatment options, and then you bring your values to this decision-making process. So what are some of your values? So for example, if you are afraid of needles, you can tell the provider. And oftentimes in these discussions, nobody likes needles, but hopefully you'll see that with discussions with our healthcare providers, they can talk to you about what other patients typically do and think about, obviously in a de-identified fashion, but they can tell you, I know no one likes needles, but once people get started, they actually find that it's something that they could do conveniently at home, and it's something that they don't need to do frequently, such as, for example, taking a pill. So those are the discussions that can be had. Also, if you travel a lot, for example, maybe having something that's less frequent of an injection is important. So make sure that you convey what is important to you to the healthcare provider and to get feedback. And it is also important to know that something that may be considered really important to you, however, the cost of that could be something of getting a drug that's of lesser performance for your psoriasis. So not only should we identify the different factors, also be able to really prioritize them and understanding how your psoriasis outcome may be affected by its different factors. So let's talk about questions to ask when deciding on the treatment. And here are a list of the questions. It's important to really think about what questions are important to you, and you may already have some answers to some of those. So please feel free to select ones that are most relevant. I would say do give your healthcare providers a chance to kind of talk about the different treatments because they may have answered some of the questions. But just to be comprehensive, it's useful to have this list to make sure that we have not forgotten about certain things that we want to ask about these treatments. So examples are, what is the advantage of taking this treatment instead of others? This is important. Why are we using drug A versus drug B or C? How is this treatment given? Is it by shot? Is it taken orally? How often? How effective is it? This is important to know, right? Because maybe one medication is taken less frequently, but if it's less effective, you need to know that. What are some of the possible side effects and long-term risks? And I would add, when we think about the side effects, one thing I always educate my patients is that not everyone gets the side effects. So what you want to know is what proportion of patients actually experience the side effects. That's number one. Number two is how reversible these side effects are. Now, if side effects upon discontinuing the medication are reversible, then that needs to be taken into consideration versus side effects that are not reversible. But probably most important thing to note is that what is the likelihood that you are going to experience that side effect? And this is because when we look at the package insert or when we look at commercials on television, you may hear a lot of different things. This could occur, this could occur, and this could occur. But what's lacking is a proportion of patients that this actually happens to. And without that information, it is really difficult to make a decision on the treatment that you are going to take in the long run. And other things to ask is, will I need to do tests or blood work while on this treatment? And who do I contact if I experience problems? What do I do if my insurance doesn't cover this treatment? And what is my next option if I do not want to do this treatment? So understanding these options and asking providers these questions are important. Now, let's talk about questions that are specific to achieving the target. Again, the ideal target is to have the body surface area of psoriasis involvement being 1% of your body surface area or less. And the way that I would approach this, just in case your healthcare provider may not be familiar with the treat to target recommendations, is perhaps a little bit gently. You can say something like, oh, I had read about this treatment target recommendations about psoriasis or heard about that. Do you happen to be familiar with that? And ask them, how much is my BSA right now? How much my body surface area is impacted? This will be important to know just for our own informational purposes as well. Not only how severe is your psoriasis, but also importantly, where are you in terms of achievement of treatment goals? And then you can ask, can we talk about our treatment goals? If you ask that question, probably nearly 100% of your providers will say yes. And you can say, well, I would like to really think about improve the degree of response I'm seeing, like to lower my body surface area that's affected by psoriasis, and what can we do about that? Also, you want to ask, how long will it be before I see any improvement, if there are any changes done to a regimen or if a new treatment regimen is instituted. And if you've been on the treatment for a while, you can say that I've been on the same treatment for this period of time. I've seen some improvement, but I'm not quite down to 1% or less surface area yet. What can we do? How can we think about this? You can also say, if you've been on the treatment for a longer period of time, really express that. And you can say, I'm not seeing an improvement. I'm hoping for more improvement. What are some of the potential next steps? I think even if the provider explained to you later that it may not be a good time or it may not be a good choice to change your treatment, I think understanding that rationale would be really important for you. So these are all some of the questions around achieving your target that you can ask. Now, I want to briefly talk about some of the challenges to adhere to some of these different types of treatments that I talked about. Biologics, again, is given as an injection. So sometimes when people are first starting out, they may find it challenging to know how to do it. But there are a lot of support programs out there, both by the manufacturers as well by other entities that will teach you how to do the injection and get you familiar with that. For the oral medications, one of the key challenges to adhere to treatment is actually remember to take the oral medications. So think about ways that you may want to institute to have a reminder system for you. Phototherapy, one of the key drawbacks for this is that it's time consuming, especially if you're doing in-office phototherapy, that in those situations, you have to drive to the healthcare facility to undergo the phototherapy treatment. So even though the treatment itself may only be 5 minutes or less, you may be spending half an hour or longer on the road going to the healthcare facility, and then you need to come back. So you may want to talk to your healthcare provider about whether there are home phototherapy options available. For topical therapies, it can be messy and inconvenient to put on. You may forget to put on. And also, when you have large body surface areas, it can be difficult to put on. Now, it's very important as we're talking about various therapies, we really think about this as a balance. It's a balance of benefit versus risk. So you want to think about benefit of treating, which are reduced symptoms, so clear skin, less psoriatic arthritis, less arthritis pain, less itching. So these are all the benefits of treating. How about the risks of treating? Risks of treating are you try to balance the likelihood that you may experience any of the side effects. Now, what's not written here that's also important to think about is what's the risk of not treating? If you are not treating your psoriasis, what is the decrease in quality of life that you're experiencing right now as a result of not treating the psoriasis? What are you missing out on in terms of what you want to do in life and also in terms of your interactions with other people? As I tell my patients that my role is to treat them effectively, make sure they achieve treatment target so that they can actually devote their energy onto parts of their lives that are really important for them, so that they can spend as little time as possible actually thinking about their psoriasis. Now, how do we assess your progress? Probably the most effective ways is to have regular appointments with your provider probably at month 3, for sure, if you're starting a new therapy. And if you're doing well, you can do every 6 months appointments. But if you're not doing so well, consider a frequency that's more frequent than that. You want to think about maybe documenting some of the changes. If you're flaring, take some photos, because that can be very helpful for the provider when you go in and talk about, say, wow, I know I don't have any psoriasis right now, but I've been having some flares recently. Just want to show you really quickly, some of the photos of my flare. There are apps that are out there that can track the symptoms if you have the time to do so. And it's important that you talk with your provider if you're not on the progress to getting better, or if you are slow on the road to getting better, really talk about what other treatment options are there. Obviously, in addition to staying on the same treatment plan, to think about changing dose of treatment, trying combination therapies, or switching therapies. So I just want to highlight as an opportunity to talk about examples of a patient provider using treatment targets. So for example, this says John Smith, this is hypothetical patient's name, a 54-year-old man with a 25-year history of psoriasis. And the symptoms are really having the severe psoriasis plaques that can itch on the scalp, trunk, arms, and legs. The patient had previously tried, for example, Humira and Enbrel with some effectiveness, but noticed that these drugs have lost efficacy over time. So the provider says, well, we can think about other options. And if you were John Smith, you would be saying something like, yes, I had tried these before while they worked in the past, but for some reason that they're no longer working. And I would like to consider something that's more effective. So in this case, perhaps through joint decision-making, if you're the patient, John, you can express your dissatisfaction with the treatment. And you can also say that my body surface area, my BSA is 10% now. It's going back to how it was before. And I really want to think about getting it to 1% or less. What should we do? And I think most providers will be very receptive to that, and then really think about other treatment options where they can help you achieve these treatment targets. So in this case, after starting on Cosentyx, because it's a new systemic medication, especially a biologic that we're starting, the patient, John Smith, comes back at 3 months follow-up to check on how he is doing. And as you can see, BSA is now 1%. So because the patient is now at the ideal target, we can continue the Cosentyx at the same dose and follow up in 6 months. Now we're going to pivot a little bit and talk about a different patient, Miss Mary Johnson, another hypothetical name, and a 35-year-old female who also have moderate to severe plaque psoriasis. Now this time on the legs predominantly, and it's causing a lot of distress. And she had not been treating her psoriasis. So now this is what we call treatment naive patient. This patient has not started any treatment. And one thing I may want to know is her body surface area, because the word moderate to severe plaque psoriasis could mean different things to different people. Her psoriasis could be as severe as covering 50% of her body surface area, or it could cover, let's say, 5% or 6%. So it's really important to think about quantifying that. So in this case, Ms. Johnson is started on an oral medication, something called Otezla. At 3 months follow-up, she has seen 50% of improvement from her baseline of BSA. And what that means is that, for example, if her baseline BSA is 10%, let's say at baseline, if 10% of her body surface area is affected, at 3 months, 50% improvement would mean that she is now down to 5% body surface area involvement. So now, has she achieved the acceptable level of improvement? If you remember, the acceptable level of improvement at 3 months after initiating a biologic therapy is either body surface area of 3% or less, or at least a 75% improvement overall from the baseline severity. So because she only achieved 50% improvement compared to the baseline, here the provider added an additional topical steroid prescription in addition to Otezla to treat the stubborn patches. So in this case, at 6 months, her BSA is 1% or less, so she has achieved the target. So what does the future hold? I think it's really important that we inform as many patients as well as providers about to treat to target, because treating to target will invariably help to improve your quality of life and help you really focus on things that are most important to you in life. And hopefully it's not your psoriasis. And then also other things that future holds are really measure the impact of treat to target on health outcomes. This is really important. Now we have the targets, we want to really understand how meeting these targets can affect our health outcomes, not only in psoriasis, but in other areas such as quality of life. And we can update the targets as new medications come along that are even more effective, and also as new ways of measuring the disease become available. So those are some of the things to consider. Now, I want to conclude with 2 slides of key takeaways. Number 1 is that treat to target is important, and any treatment regimen can be used to help a patient achieve these treatment targets. And treatment options may vary, and so you and your provider need to work together to select treatments that's appropriate for your disease severity, for the location that's affected, as well as have that decision be based on your overall health status. So as you can see, the treating to target approach is defined and it's measurable. It has a time period, but doesn't tell you what treatment that you use to get there. And that is intentional because each person's situation is different. And we want to make sure that the treatment choices that are selected is appropriate for you, such that the benefits of treating to target outweighs any potential risks. And then finally, underpinning all of this, the communication between you and the provider is key to making these treatment decisions. Treat to target may take some additional time and effort, especially through the dialogue between you and your healthcare provider. But I do personally agree that the results can really help to improve your overall health and quality of life. Thank you very much for your time today.
Thank you, Dr. Armstrong, for providing such an informative presentation about treat to target. If you as the viewer have additional questions about managing your disease, need information about treatment options to help reach your goal, or help in finding a physician, contact our Patient Navigation Center by phone, email, or text as indicated on the screen. The Patient Navigation Center offers free and personalized assistance to anyone impacted by psoriasis and/or psoriatic arthritis. This concludes our presentation about treat to target.